Dear colleagues, good morning. My name is Tufan Tarcan. I'm a urologist from Istanbul, and it is my great pleasure and honor to be with you again in the SIUD Congress. I'm very sorry that I cannot be physically with you because of the travel restrictions due to pandemic. I would like to thank Professor Marco Soligo and Professor Vincenzo Limazzi for their very kind invitation. I also would like to thank Professor Enrico Finazzi Agro, who is chairing my session. My talk will be about the pharmacological treatments for bladder outlet obstruction in male patients. This is my disclosure slide. I have been a speaker or researcher or advisor for the pharmaceutical companies that you see on the slide in the last 2 years. Besides, I'm currently acting in the committees or in the board of certain international organizations in the field of functional and female urology. So first, I think we have to appreciate that bladder outlet obstruction is not a synonym for male LUTS. This is a very well-known phenomenon. Actually, bladder outlet obstruction, as you know, is a urodynamic parameter. It's a diagnosis of pressure flow studies. On the other hand, male LUTS has a multifactorial etiology as shown in the EAU guidelines. When we evaluate a patient by urodynamic studies, we may find benign prostatic obstruction, detusser underactivity, or detusser overactivity, as shown here by the arrows. These can be also found together in the same particular patient. So, although the title of my talk is Bladder Outlet Obstruction, I'm also going to focus on the pharmacological treatment of certain drugs in the male lower urinary tract symptoms. So another important point is to understand the pathophysiology of those patients with bladder outlet obstruction. Unfortunately, it is not completely understood. The review paper by Ferdinando Fusco and Associates has very well actually demonstrated what we know today about the progress of the disease. In the first phase of the bladder obstruction, we know that the bladder undergoes hypertrophy. It is actually smooth muscle cell hypertrophy. In the second phase, which is called as the compensation case, there is a progressive extracellular matrix deposition within the bladder wall. And in the third phase, that is the decompensation phase, the clinical picture becomes more severe with urothelial dysfunction, neuron degeneration, smooth muscle cell degeneration, and there is high levels of extracellular matrix deposition here and in this phase. And usually we see our patients more with OAB or underactive bladder reaching the end stages of the pathophysiology. Of course, there are so many other factors that may influence the progress. For example, the host factors. If the patient is diabetic, this pathophysiological deterioration may be more quick, or the bladder habits of the patient may also affect us. And also we know as of today that tissue hypoxia or bladder ischemia is a key factor which accelerates or which plays a major role in the pathophysiology. So when we treat our patients, it's also our goal to prevent this progression. As you see on this slide, it is the bladder who is responding to bladder outlet obstruction. So our main role is to prevent the bladder physiology and morphology. It is not the only symptoms that we are trying to treat here. So what are our options in the pharmacological treatment of male LUTS associated with bladder outlet obstruction? We have the alpha blockers, 5-alpha reductase inhibitors, muscarinic receptor antagonists, beta-3 agonists, PDE5 inhibitors, and phytotherapy, as also shown by the EAU guidelines. I'm not going to talk much about the phytotherapy since there is not much evidence related to their effect on bladder outlet obstruction, but I'm going to focus on the other pharmacological options today. Again, I have to mention that the first-line management of these patients is always education and lifestyle advices before starting the pharmacological treatment. Alpha blockers are certainly the most commonly used pharmacological options in that patient group. The mechanism of action is not clearly understood. We know that they reduce the prostate tone, and we also know that they decrease the bladder outlet obstruction index. And bladder outlet obstruction is actually not only Qmax, it's a function of Qmax and P-detisur at Qmax. There are also other possible mechanisms that may be involved. For example, their effect on the urinary bladder or spinal cord or blood vessels can also play a role in the management of these patients with alpha blockers. We know that alpha blockers do not affect the prostate size. And usually, as you see here within the red rectangle, the alpha blockers are first choices after the first-line management of these patients as the pharmacological treatment. So usually a Qmax may be misleading when we determine the effect of alpha blockers because we also need to measure the P-detisur at Qmax in order to decide on the obstruction. So again, here, Ferdinando Fusco and Associates have very well reviewed the available studies, and they have shown that alpha blockers improve actually bladder outlet obstruction in patients with LUTS and benign prostatic enlargement. This is more achieved by a reduction of the P-detisur at Qmax. And it is also shown that the effect is higher in patients presenting with urodynamic obstruction at baseline. And therefore, we should not look only at the Qmax when we evaluate the effect of alpha blockers on bladder outlet obstruction. You have to perform a pressure flow study in order to understand what's going on. And actually, all alpha blockers as a class effect decrease the bladder outlet obstruction index. These are the currently available alpha blockers that we know very well, and all are recommended by the EAU guidelines strongly in the management of male LUTS. And all alpha blockers have a similar efficacy with rapid onset of action. The randomized control trials have shown that the IPSS is reduced by 30 to 40% by alpha blockers, and both storage and voiding symptoms decrease. And Qmax is increased by 20 to 25%. Again, the effect on bladder outlet obstruction may be more relevant if we take the P-detisur at Qmax into consideration. It may be more efficacious in patients with smaller prostate, according to long-term studies. There is a similar efficacy across age groups with long-term persistence, and we know that alpha blockers do not prevent occurrence of urinary retention or need for surgery, according to the randomized controlled trials. Another commonly utilized pharmacological option in the treatment of bladder outlet obstruction that is associated with benign prostatic enlargement is 5-alpha reductase inhibitors. And here we have two choices, namely dutasteride and finasteride. As we know, 5-alpha reductase enzyme has two isoforms, type 1 and type 2. Finasteride inhibits only type 2, whereas dutasteride inhibits the both types. And pharmacological treatment with either drug results in similar symptom improvements so far, according to the studies. However, dutasteride may have a better profile in reducing the risk of prostate surgery or acute urinary retention, as shown by Pirozzi and associates. Dutasteride and finasteride are shown to be equally effective in prostates larger than 40 milliliters. However, dutasteride is shown to be also effective in prostates between 30 to 40 milliliters. After 2 to 4 years of treatment, 5-alpha reductase inhibitors improve the IPSS by approximately 15 to 30%. They decrease the prostate volume by 18 to 28% and increase Qmax by 1.5 and 2 milliliters per second. Furthermore, they reduce the long-term risk of acute urinary retention and need for surgery. And dutasteride reduces lower urinary tract symptoms at least as much as the alpha blocker tamsulosin in the long term, especially in larger prostates. And the combination of alpha blockers and 5-alpha reductase inhibitors is maybe the most effective treatment, which decreases the bladder outlet obstruction index and also prevents disease progression. The EAU guidelines for that reason strongly recommends the combination treatment to men with moderate to severe LUTS and increased risk of disease progression, which is the prostate volume of more than 40 milliliters, for example. And this recommendation basically is taking the two studies into consideration, namely the MTOPS and COMBAT studies that we know very well. The question, do the 5-alpha reductase inhibitors decrease the bladder outlet obstruction? The answer to that was yes. In this study by Vada and associates on 52 patients with benign prostatic enlargement who were not satisfied with alpha blocker monotherapy, and dutasteride add-on therapy was started. All had prostates larger than 30 milliliters. And as you see on the table, after 24 weeks, the bladder outlet obstruction index significantly decreased after dutasteride add-on treatment. So both alpha blockers and dutasteride and also finasteride decreases the bladder outlet obstruction index to our knowledge today. Furthermore, the 5-alpha reductase inhibitors prevent the disease progression, and Sindola and et al. Have shown that the both event-free times for hospitalization and surgery of BPH were the best for the combination treatment arms, as you see here with the green line on the slide. So, of course, male LUTS is not only emptying symptoms. We may also face storage symptoms in our patients. And we have here basically two options, namely the antimuscarinics and mirabegron, as recently appeared in the field. These therapies can be applied both as monotherapy or add-on therapy, as also shown by the EAU guidelines. If you could follow this algorithm here, we may have patients with isolated storage symptoms here, and these patients may go for antimuscarinic or mirabegron therapy as monotherapy without any other pharmacological treatment. Of course, if certain parameters exist, or in another patient group who started first alpha blockers, if the storage symptoms persist, then we may add mirabegron or antimuscarinics to their treatment. We know that the male LUTS is not always used and not always caused by the prostate. So actually, there are also male patients with primary OAB that we can treat as a conventional OAB patient. So there is a level of 2 evidence that antimuscarinic monotherapy can significantly improve urgency urinary incontinence, and increase daytime frequency. So therefore, there is a strong recommendation, again, by the EAU guidelines, to use the muscarinic receptor antagonists in men with moderate to severe LUTS who mainly have bladder storage symptoms. There are, of course, safety concerns, especially regarding the detusor underactivity and post-voiding residual urine in the long term. Besides the drug-related adverse events, which are acceptable, for example, RCTs have shown 3 to 10% withdrawals in the antimuscarinic arms, which is similar to placebo. The increased PVR in men without bladder outlet obstruction is minimal. That shows a safety. Therefore, only patients with low PVR volumes at baselines are currently included in that studies. So we can only comment on those patients with good detusor function with low PVRs who should benefit from antimuscarinic monotherapy. And a high PVR is certainly a contraindication for antimuscarinic treatment. What is the effect of antimuscarinics on bladder outlet obstruction? For that, to answer this question, we may review the paper from Paul Abrams and Associates about the safety and tolerability of tolterodine for the treatment of OAB in men with bladder outlet obstruction. There was 72 patients in the placebo arm and 149 patients in the tolterodine arm. And in the tolterodine arm, the PVR was increased for 49 milliliters versus 16 milliliters in the placebo arm. But the acute urinary retention was about 3% in both arms. The urodynamic effects of tolterodine included larger bladder volumes at first detusor contraction, higher maximum systomatic capacity, decreased bladder contractility index, and the Qmax was not changed. And according to this paper, we can say that short-term treatment with antimuscarinics, even in men with bladder outlet obstruction, appears to be safe. So what do we need? First of all, we know that the contraindication is high PVR. According to the EAU guidelines, it's contraindicated in men with a higher post-voiding residual urine than 150 milliliters, but still in the safe group of patients with lesser PVRs. We need long-term data here, plus we don't have the data in the elderly population, especially for all antimuscarinics. So still we need more research in that field. Another option is, of course, to use this antimuscarinics as an add-on treatment if alone alpha blockers are not enough to solve the storage symptoms. And again, according to the EAE guidelines, it is strongly recommended to use the combination treatment of a alpha blocker with a muscarinic receptor antagonist in patients with moderate to severe LUTS if relief of storage symptoms has been insufficient with monotherapy with either drug. Again, the PVR appears to be a contraindication for that treatment, which is more than 150 milliliters. Another option that we have in the management of storage symptoms in that patient groups is mirabegron. Although the main theory of action depends on the relaxation of the detusor muscle through beta-3 adrenoceptors by stimulation of cyclic AMP, the exact mechanism of mirabegron actually may include also other mechanisms, other pathways, for example, opening of potassium channels, inhibition of spontaneous contractile activity in the bladder, or reduction in bladder afferent activity. We know that the absolute contraindication of mirabegron, which is the severe uncontrolled hypertension, but other than that, many studies have shown that the side effect profile is very similar to placebo with mirabegron, and especially people do not show any dry mouth and constipation, which are main difficulties for us to continue the antimuscarinic treatment. Again, to our basic question, what is the effect of mirabegron on urodynamics of these patients? Well, Nitti and associates have studied 200 men over 45 years of age with LUTS and bladder outlet obstruction. And they randomized their study group either to once daily mirabegron of 50 milligram or 100 milligram or placebo for 12 weeks. And they found that mirabegron 50 or 100 milligram once daily had no negative effect on voiding urodynamics. That means Qmax or P-Deter at Qmax or bladder contractility index versus placebo after 12 weeks of administration. And the overall change of in PVR with even mirabegron 100 milligram was not considered clinically meaningful. Again, in the short term, this study has shown that mirabegron does not affect the voiding phase in patients with bladder outlet obstruction. So it appears to be a safe drug for that reason. So the EAU guideline indicates the evidence that mirabegron improves the symptom of OAB, including micturition frequency, urgency, and urgency urinary incontinence, and also indicates that patients prescribed mirabegron remain longer than the patients prescribed antimuscarinics on treatment. And there is a weak recommendation about using beta-3 agonists in men with moderate to severe LUTS, but I think this recommendation will change soon. Of course, for the patients who mainly have bladder storage symptoms, of course, we need long-term studies, especially in the elderly population, to approve the cardiovascular safety here. Another option that we have in the pharmacological treatment is the phosphodiesterase 5 inhibitors. Again, here the exact mechanism on LUTS is not clear. The basic theory is that the PDE5 inhibitors increase the intracellular cyclic GMP and reduce the smooth muscle tone of the detusor, prostate, and urethra, but there may be other pathways that affect the efficacy. For example, PDE5 inhibitors may alter the reflex pathways in the spinal cord and neurotransmission in the urethra and the prostate and the bladder. Chronic treatment may increase the blood perfusion and oxygenation, so improve the ischemic states in the lower urinary tract. And it's also shown that they could reduce the chronic inflammation in the prostate and bladder. So there may be more than one mechanistic pathways involved in the management of phosphodiesterase 5 inhibitors. Only tadalafil so far, which is 5 milligram once daily, is licensed for the treatment of male LUTS. According to the Cochrane analysis in 2018, which included 16 RCTs, there was a small reduction in IPSS compared to placebo after PDE5 treatment. There was no difference between PDE5s and alpha blockers in IPSS in some studies. Qmax did not significantly differ from placebo in most of the trials, and unfortunately, most of the evidence was limited to short-term treatment up to 12 weeks and of moderate or low certainty. So the PDE5 inhibitors are shown to improve the IPSS, the IEF score, but not Qmax, according to the current evidence. A more than 3-point total IPSS improvement was observed in 60% of tadalafil treated patients within 1 week, but this reaches up to 80% within 4 weeks. So there's a strong recommendation as of today by the EAU guideline to use the PDE5 inhibitors in men with moderate to severe LUTS with or without ED. So in conclusion, we have many options to treat our patients with male LUTS, especially with bladder outlet obstruction. Bladder outlet obstruction is again a urodynamic term, and we know that alpha blockers and also 5-alpha reductase inhibitors can decrease the level of bladder outlet obstruction. And so far, the alpha blocker with 5-alpha reductase inhibitor as the combination treatment appears to be the best choice to decrease the bladder outlet obstruction index and also prevent the disease progression. There is a certain group of patients with persistent storage symptoms or with initially storage symptoms. They can be treated with monotherapy or add-on therapy of antimuscarinics or mirabegron. Unfortunately, long-term data is still missing for that treatment options, and therefore close follow-up is very important. And for especially patients with storage symptoms and or concomitant erectile dysfunction, tadalafil mono or add-on treatment appears to be a viable option. Again, the exact pathophysiological mechanism or mechanistic pathways of this treatment is not known, and also the long-term studies are needed to really understand their efficacy in the very long term. I would like to thank the organizing committee. Once again, I would like to thank you for their very kind attention to this lecture, and I'm ready now for your questions if you have any.